Before we start, I'd like for you to just take 1 second and think about the 3 most important people in your lives. Just 1 second. And with those people in mind, keep in mind that one of those 3 either has prediabetes or diabetes. 1 in 3 Americans has diabetes or prediabetes. It's a huge issue in our country. It's something that we're struggling with. We are struggling with it so extensively that we need to have the community involved for help. And that's what we're going to talk about today. Community involvement, being active in this problem, dealing with it from the community perspective and what we can learn from that community. Today I want to introduce Dana Lewis and Michelle Lichman, and they will each tell you a little bit more about themselves. One of the people that we couldn't have here, and we'll introduce her in a moment, is Mila Ferrier. And so with that, I just would like to kind of get started here. And I want to talk about movements in healthcare, major movements in healthcare where we really needed to have leadership. In the 1850s, Dr. Rebecca Crumpler actually was a nurse at the time in New England, and during that time, nursing was not very well defined, and she was doing an excellent job. And somebody said, "You know what? We think you could do more. You could offer more if you became a physician." And so, Dr. Crumpler is believed to be the very first African American female physician in the United States. She already had a couple very difficult obstacles to overcome. It took 8 years for her to be admitted into medical school. She tried multiple times, and you can imagine the level of pushback from the medical community, from hospitals, and from educational institutions. But she did it, and when she was done, in 1860, when she graduated, she went on to treat those who were emancipated slaves after the Civil War, and that was what her entire career was. One of my favorite heroes in medical movements is Florence Nightingale. I'm a nurse myself. I've been following Florence Nightingale for years. Not only was she a nurse, but she was also a skilled statistician and mathematician. And she was able to use those skills to move the needle. She was able to, people were laughing at her at first when she talked about sepsis in hospitals, especially around the Crimean War. And eventually, though, she was able to prove to them with data and knowledge that changes needed to take place. And those changes that she put together are actually still occurring to this day. And last year, or I believe it was last year, a mural has been in development. And this is a mural that is put together by Jan Hayworth, and she's the Grammy Award-winning artist who did the album for Sgt. Pepper's Lonely Hearts Club Band. And so many of us remember that album cover. But she now has done this to honor female leaders and female scientists and female innovators throughout history. And so this is a beautiful traveling mural that goes around. We had it in Utah last year. And actually, Michelle was able to contribute to that mural as one of the artists. And if you look carefully in the mural, and it may be somewhat hard to see, there's somebody on the stage that's on that mural that is a true medical pioneer. I'm so proud to be able to sit on the stage with Dana Lewis, who is a true medical pioneer. And we're going to hear the work that she has done and the work that she's going to continue to do, because really she has just started. The other pioneer who could not be here today, Mila Ferrier and her husband Jimmy, are parents of a child with diabetes. And they have been dealing with that issue for many years now. And I really think of Mila as another pioneer in this field. She is a mother who turned her passion and the love for her son into service to other people who have diabetes, and now she's one of the leading voices in diabetes, literally worldwide, especially in the Spanish-speaking community, all the way down to the tip of South America. And When I started coming to Medicine X 5 years ago, the big push was to have patients involved in research. And Mila is my co-PI on a research project funded by PCORI. And I couldn't be more proud to have Mila and Jimmy as co-PIs on that project. We have what's called the Intercultural Diabetes Online Community Research Council. We're in our 3rd year of funding at this time, and we are looking at ultimately, our goal would be, how could we see the diabetes online community be prescribed as an intervention? I'm going to tell you a quick story, and it occurred last year, and actually both of us were present when this story occurred. There was a hackathon in Salt Lake City where people were learning about the process of developing do-it-yourself artificial pancreas systems. And Michelle and I were so gracious that we were invited to attend this hackathon. And there was a woman who was probably middle-aged. She was very active in her work, and she talked about, and she had one of these artificial pancreas systems, and she talked about how one morning she got up, she took a shower, she put on her makeup, she ate her breakfast, she got in her car, and she got halfway to work and forgot completely that she had diabetes. And that's kind of the message that we want to send with the work that's being done by Dana and others like her, for people to be able to live the fullest life they possibly can. When this person told us this story, it wasn't like I just said it. It made us all tear up at the moment. She told it with such passion, and it really had changed her life. And so Mila, who I mentioned a few minutes ago, and she'll tell her story in just a minute here. She lives in Florida, and unfortunately she is not able to get out of town because of the hurricane problems. And by the way, there's more weather coming to that general region. And so she was in the airport all day yesterday, but she did agree to send us a video today. And by the way, I know Mila's watching now, so Mila, we love you and we miss you here, and say hi to Jimmy from us. So here's a brief introduction from Mila.
Hola, my name is Mila. I am not able to be there with you today as I had hoped due to last week's hurricane that hit Florida. I'm very disappointed, but at least with this video, I can be able to share my experiences with you. Our diabetes story started 11 years ago when my youngest son, Hanu, was diagnosed with type 1 diabetes. He was only 3 at the moment when we started to manage this very complex and stubborn disease. As most of you might already know, when you manage type 1 diabetes, your main task is to keep your blood sugars in range for as long as possible during one day, those very long 24 hours. The next day, you face the same challenge, trying to keep your blood sugars in range for as long as possible. When we try to find that perfect balance between food, insulin, physical activity, and many other factors that are uncontrollable, such as hormones, it's sometimes hard. How do we try to do that? So we were pricking my son's finger 10, 15, and even 20 times a day during every single day. It was very painful for him and for me. As a parent, the last thing that you want is to do harm or cause any pain to your kid. Now, fast forward to 2012. Jaime started using a CGM, or a continuous glucose monitor, which changed not only his life, but our entire family. For the first time since his diagnosis, I could finally close my eyes during my sleep without worrying about a hypoglycemia or a severe hypoglycemia. With the CGM, we were able to see his blood glucose levels and tendencies, which allowed us to make timely and proactive decisions in his diabetes management. This was a game changer. But still, we were missing something. When Jaime was not at home, he was at school, baseball, or tennis practice, we had to text him the same question over and over. What's your blood glucose reading? We were constantly looking for that perfect balance between physical activity, food, and insulin that I mentioned earlier. It was very difficult because we want him to grow and feel like any other kid at school or on his team, but we cannot afford to ignore his type 1 diabetes. But at the same time, we do not want diabetes to be the center of our conversations. Thanks to social media, I came across Night Scout and the amazing hashtag "We Are Not Waiting." Of course, my family is not waiting. When your son's health is on the line, you will do whatever it takes to keep him healthy. I cannot wait until the government approves better technology that for them might seem cool and innovative, but to our family is something vital and life-changing. Not only with better outcomes, but also with a better quality of life. Being able to see and monitor the 282 daily blood glucose readings from his CGM provides us the opportunity to make timely and proactive decisions, allowing us to sleep at night, make sure he's okay while playing sport. And for the first time since his diagnosis, it allowed me and my husband to travel without kids. For my family, the CGM has no price. As a family with diabetes, we have learned and benefited from peer support on social media. We cannot thank enough those who have the knowledge and the selfless desire to make all these amazing hacks available to our diabetes community. We are not waiting. When dealing with health conditions, we cannot have patience and wait for others to make decisions for us. We are a strong and fearless diabetes community. And I know that in the future, the diabetes care and management is being shaped by our members, the members of our diabetes community. Thank you so much for listening to our story. And now I'm just going to be answering some questions for you. Hi. Do you mind giving your family access to your CGM data?
No, because knowing that my family is my safety net gives me lots of peace of mind. Because sometimes when I'm training, I forget to check my phone to see how my blood sugar is going. And it doesn't put as much responsibility on my hands because sometimes I'm focusing on my work, on my baseball skills, not on my blood sugar. So knowing that my parents would be continuously checking my blood sugar and messaging me gives me lots of peace of mind.
How does this technology help you while you play sports?
The technology has had a great impact while I'm playing sports. I used to play tennis, and I did not have a CGM at that time, so I had to check my blood sugars 5 to 6 times per game. In some instances, I even had to take some medical timeouts just to treat a low. Now I play baseball, I have access to the data, my parents have access to the data, and I can check in the middle of the innings, and my parents can check it throughout the whole game. So now we prevent those rather than treat those.
As you can see by Jaime's opinions, diabetes technology has come a long way, and this is just the beginning. We are not waiting. We're going to keep working and searching for those new things that are going to make our lives happier and healthier with diabetes. Thank you so much once again, and I'm sorry I missed you guys. Bye.
I'm so glad Mila was able to share that on video because people get really excited about the technology. It seems advanced, it seems sexy, it seems innovative, especially when I can do things like text my pancreas using Siri. But the cool, most amazing piece of this technology is not the fact that I can use Siri to text my pancreas. It's really everything Mila was talking about the quality of life. Because when you live with a chronic disease, whether it's diabetes or something else, it completely changes everything. For me, it's about the peace of mind of being able to go to sleep at night. That is why I first started hacking my diabetes. It was about first creating a louder alarm because I would sleep through the alarms on my CGM. And then that eventually progressed through collaboration with others to being able to create what became the artificial pancreas. And because it was so impactful for me, I was able to go to sleep for the first time without worrying that I wasn't going to wake up the next morning, without having to have my mom text me every morning and say, "Are you awake?" which was code for, was I alive and okay, and make sure that she didn't worry while she was across the country. I mean, the peace of mind for everybody when we have this technology available is very, very significant. But I know that if you don't live with diabetes, it's kind of hard to imagine. So who here either has kids or has heard stories about sleepless parents of newborns? A lot of people. Okay, so most people kind of understand that analogy. And what I tell people is living with diabetes is like having a 2-month-old baby that never grows up, that never moves past that stage of waking up every few hours and needing food, needing being held, needing being changed, whatever that is. That's what diabetes is like. So this technology is absolutely critical, whether we're talking about being able to remotely view it so that the burden is lifted off the person with diabetes, or whether we're talking about the ability to automatically adjust our insulin delivery. And so that's what I spend a lot of my time doing, is that automatic insulin adjustment delivery system, or what we call a hybrid closed loop artificial pancreas system. And because it was so life-changing for me, that's why I said, we've got to make this open source, not only because I used open source code and collaborated with others to build it, but if only one or two other people could possibly get that same peace of mind as I do, it'll be worth doing it. And so that's what OpenAPS, that's why it was started. It was about how do we make this available to whoever wants it. And I constantly am surprised about how many people say, I have no tech background, I have, whatever. They say all these things to disqualify themselves, but they say, we're not going to wait because we can't wait. We need this for my child. We need this for my wife. We need this for my husband. We need this for my family. And that's really what we are not waiting means. It's people saying, why would we go one more night with our lives at risk when things can be better now, when we know that tomorrow can be different, tomorrow can be better? And I've learned a lot of really important things from the community, and I really want to emphasize that we are not waiting. It often is a personal decision. It's often an individual decision, but you're part of a community who said that. And the things that I've learned from the community is you don't know what you can do until you can try. We didn't know that we would end up creating an artificial pancreas, but we just kept trying and kept iterating on the problems that we found we had the technology to solve. And also, anything is better than nothing. No, it's not perfect. No, it's not easy. Yes, sometimes it breaks. There's pros and cons to DIY, but when there's no commercial option available to you and your family, hacking something together is totally worth it. And the reason that this mantra and this movement has continued to spread across the community is because we all have been helped by so many people, by this amazing community, and we want to give it back however we can. So what's really cool about We Are Not Waiting is so much of it is open source, but not just the code and like what sounds like hard technical stuff, but also the documentation of how do you put this system together and how do you really live with this in real life? What happens when you go to an airport, when you get on a plane, when you're dealing with scuba diving and diabetes and this pancreas, like how do you do it? People pay it forward in so many amazing ways. And I think that's one of the coolest parts of this is not the tech. It's the community and the learning that goes peer-to-peer that I think is absolutely fascinating. And I'd love to pass it over to Michelle next to talk about her perspective as a clinician, because oftentimes you just hear from the patients, and that's valuable. Like, it's amazing to have patients so involved in leading a project. But I think when we think about how do we truly scale this, how do we really make this as accessible as possible to as many people, we need to be able to partner with clinicians, and that's why I'm so glad to be sharing the stage with y'all.
Thank you, Dana. One of the things that is interesting as a clinician is I think that not everybody has access to a diabetes online community because they're busy seeing patients or they don't know about the diabetes online community. So I think that there's a great number of clinicians that aren't aware. But because of the research that I do in this space, I was very aware of this, and I had actually brought it up with a couple of patients, and we engaged in a conversation. And that was several months ago. And then I there were certain patients that I had an idea of that might be really interested in this versus some others. And one of the things that was really interesting this summer was that I got a message through the patient portal, and it said, "Hello, Michelle. So I started looping today." And I thought that this was really interesting. We had a discussion about it, and I knew that he was planning to try and find the pieces to make this technology possible. And I had the feelings that I experienced were, oh my goodness, like here we go. We're on this ride now. And it's not necessarily I'm on this ride, but I'm more of this observer, but I'm also his healthcare provider, and so I want to make sure that things go right because. Really, we just want to make sure that it's safe. And so I think that this is something that a lot of clinicians are concerned about. Is this safe? What happens if my patient does this? And, how can I kind of balance that, this non-FDA approved technology versus what I know has a lot of evidence behind it? And I think one of the things that we need to always think about is there are things that we are doing in practice right now that are not FDA approved. So we're prescribing off-label. A lot of us are. We are doing, we know that our patients are sometimes reusing a lancet, which is not what is recommended, but we know that patients do that. And so there are things that are happening right now. Is this as easy as just not changing your lancet every single time you prick your finger? No, it's much more complicated. But I think that we're kind of moving into a space where we need to really consider the patient's needs, and we really need to be paying attention to what the patients are doing. One of the other things that I want to talk about is a study that we conducted where we examined the diabetes online community, specifically Instagram. And what we were interested in looking at was this continuous glucose monitor is FDA approved to be on the abdomen. And one of the things that we saw in clinic and we saw in photos online was that people were wearing them in different spots. And so what we decided to do was we hand searched almost 3,000 photos on Instagram using specific hashtags, and we found about 300 photos that depicted a continuous glucose monitor on the body. And so we coded all of those sites, and we found that, here in green in the circle, there's this abdomen where it's FDA approved, and we found that this is where people were wearing the device beyond the abdomen. And then we actually coded for what the comments said about, these discussions around specific sites. So, people are talking about wearing it on their arm, or they're having discussions about wearing it on the calf, and we found that the failure rate that people talked about in this discussion on Instagram, the failure rate was similar for the abdomen, the arm, and the thigh. And I think that tells a story. Instagram's not perfect because it's just a snapshot in time. It's not like you're following someone for the whole lifespan of their wearing a continuous glucose monitor. But there were discussions about whether or not someone had used a site in an alternative site. And so I think that this shows that patients have realized that there might be other ways to wear their devices, and perhaps it's more comfortable. Perhaps it's something that they want to give their abdomen a break because they know they want to use it for insulin pumps, or they might want to, for fashion reasons, they might want to have it on a different location. So I think that we need to take in some of the patient desires into consideration. One of the other things that I think is really important to talk about is some of the headlines that are coming out, especially lately with the insulin for all kind of movement with regards to how expensive insulin is. In the last year, there's been lots of discussion about EpiPens and how expensive those have been. And there's in the food allergy community, there's been this kind of maker movement of like a do-it-yourself EpiPen. And I think one of the things that's interesting about the diabetes space, you need insulin to live. And if you can't access insulin because it is so expensive, it's problematic. And so what we see in the online community space is this trading of supplies and insulin. And with the recent hurricane, there was a lot of that where people had excess insulin for one reason or another, and they were willing to share. And I think that goes to show that there's real altruism in the community, like they want to help another person. But I also think that this really highlights the need for us to be able for improved access to insulin for other items that are life-changing with regards to health. If people can't, how do we expect people to improve their health or able to manage a condition if they don't have access to the tools? So one of the things is this huge FDA stamp, is it approved or not approved? And I wanted to share one other story about something that related to the off-label thing. One of the things that we do in our clinic is someone might need an insulin pump, and it's the cartridge for an insulin pump ranges from 200 units to 480 units. And sometimes people need more than that within a 3-day period. And what this does is it makes it so that a patient might have to change their cartridge more often. And if you talk to manufacturers, they'll say, well, you can change that pretty quickly. It's not a big deal. but it takes time and it can be a big deal. And so one of the things that I know some clinicians are doing, me included, is we're using concentrated insulin off-label in insulin pumps. So there's an insulin that's been around for quite a while called U500. It's 5 times the concentration of insulin. It's not perfect in that the way that insulin works is similar to kind of a mix between regular insulin and ultra lente, so it's not a rapid-acting insulin, but with the recent release of a rapid-acting insulin that's double concentrated, we've actually been able to see really great results, and people are happier because of this, because they don't have to change their set as much. They feel like absorption is better because they're not pushing so much insulin through an insulin pump site. And so there's real great opportunities for us to explore alternative options, which can really help quality of life. And so I just want to make sure that that's understood. So I think that Perry's got a few questions.
Sure, yeah. Thank you two both so much for your contributions. And I want to ask my first question to Mila, because I did have some questions planned for her. As a parent of a teen with type 1 diabetes, what is the scariest thing for you? And what does diabetes technology do for your family dynamics?
Oh, we lost.
Data. Hamid's brothers have learned how to take care of him, and they know that they have to be aware of what's going on with his blood sugars, especially if we are traveling and when they are at baseball practice, they are going to be his support net there. Technology can make our lives a lot easier, but only if you learn how to use it correctly and take advantage of its benefits. For me, nighttime lows are very scary. I believe as moms, we have a sixth sense that will wake you up in the middle of the night. Even before we were using a CGM, I would woke up and say, hey, let me go ahead and check on his blood sugar. And for some reason, he was dropping or he was low. So having that safety net, having that iPad set by my bed, where I can just look with one eye and see what's going on, or having the alarms at night, has helped us to sleep, to be more confident, and to feel safer.
Great, thank you, Mila, and I know you're watching out there. I do have a few questions for you two, but before I ask any questions, I think it's odd that it looks like we're color coordinated. What's the story with that?
So I created a shirt. Somebody actually mentioned this outside yesterday. They were talking about genomic data on a scarf, and they're like, you know those guys who wear code on your t-shirt? I was like, wait till you see what I'm wearing tomorrow. Because I love this idea of wearing code on your t-shirt, or code in that way, because it's an expression of freedom of speech. You can share code, and that's what we do in OpenAPS and other parts of the community. Share code as a freedom of speech. You're not distributing a medical device, you're just expressing yourself. And so I used Spoonflower, which is a custom fabric printing site, to create fabric and create this shirt. And I had the opportunity to see these guys at a conference a couple months ago, and we were talking about this panel and preparing for it, and they decided that they wanted to print fabric and also have clothes made too. So they too are wearing our community's artificial pancreas code on their clothing items.
And we have one more item for you.
Oh my gosh.
Teddy bear from our team.
That's adorable. It's a teddy bear with the artificial pancreas code. Thank you guys so much. It's amazing. I love it.
All right, I guess I'll ask you a real question now. So Dana, can you tell me, what can clinicians learn from the do-it-yourself community?
That's such a good question, because I think the learning goes both ways. I appreciate the challenge of clinicians that when a patient walks in and says, hey, I did this thing that you've never heard of before, it probably throws clinicians for a roll. But I think the best clinicians are the ones who are having an open mind and saying, okay, first tell me, why did you decide to do this? And how did you decide to do that? And why do you continue to do it? Because when you decide to do an open source or a DIY thing, it's not just in that moment, but you decide this is valuable to me and I continue to use it. So I think it's important for clinicians to understand the why, because then they can, have an educated conversation about, well, are you aware of the safety risk? And as far as I can tell, most patients are very deeply aware of, here are the pros and the cons and the risk of using this technology. But to me, the benefits outweigh the risk. And it's important to have a clear conversation and kind of get that out of the way so you can talk about, optimizing and everything. But I also think, DIY is not going to be right for everybody. But what we're learning in the DIY community directly translates to how patients will be using the commercial versions of this technology. And so clinicians who listen now and work with patients who are kind of on that very bleeding edge, they have a huge advantage. So when this commercial technology comes out and patients are on it and they need help, they've got to start on the learning process of figuring out how to help patients be successful on this technology.
Well, I have to say I am honored to wear your pancreas. Thank you so much. And Michelle, I want to ask you kind of a follow-up question related to that, and that is, what is the best way to bring DIY or DIY interventions to the provider's office? And even maybe it's somebody who has never discussed it with you before.
So the hope is, I mean, we've talked a lot about patient-provider communication and building that relationship. So hopefully it doesn't feel like it's such a hard thing to bring up in the first place, because there should be trust in that relationship. So that's key first. We need to make sure that we're having those great relationships between patients and providers. But second, I think that as a provider, I'm always interested in the why. How does it make you feel? Why was this so important to you? And I think that if you think about all of the day-to-day challenges that someone might have with diabetes, it's really important to consider how much ease of peace of mind was talked a lot about, how much sleep. Sleep is part of quality of life, and it actually, if you get a poor night's sleep, how it affects you the next day, how much energy you might have. Not just physical energy, but mental energy as well. And so I think that if you can talk and have an open dialogue with your healthcare provider, who's hopefully open and has a great trusting relationship with you, it shouldn't be a problem. If you're not in a position where you feel like you're having that trusting relationship with your healthcare provider, you might need to change healthcare providers, because really this should be an open dialogue that people are willing to have with you.
And we have heard people from the community who've said, my doctor was super jazzed about it, very supportive, and other people who've said, you know what, my doctor, was not happy at all and was actually angry. And there's been luckily way more of the excited providers who want to have a conversation and want to understand why, but have been some people who've chosen to change healthcare providers because they were not comfortable with a provider who was not supportive of something they felt was like critical to save their lives. And I do have empathy for providers, because I can imagine it can be really frustrating to, feel like you don't have solutions that work for patients, and to feel like patients have to go out there and do it their own. There's probably a feeling of helplessness on the healthcare providers too, where you can't make things go faster and you desperately want this technology. So I do have empathy for providers who are dealing with that scenario too, but my hope is, because the community has said enough is enough, we're not going to wait, that also puts some power back into the hands of providers who can talk about off-label things, because this is an off-label thing, and hopefully that conversation spreads between more patients and clinicians.
Absolutely. I think that it really helps if there are hackathons or meetups related to this in certain communities. So in my community, Mikhail Curry, she is the first person with OpenAPS in Utah, and she and her husband are really great at wanting to kind of share the message and trying to create opportunities where people can learn more about this. And that's where Perry and I initially learned quite a bit more about this process, but also there's quite a few patients who go. And so if I have a patient who is interested in it after we've had a discussion, they kind of go to one of these meetups or they look online. But I know that I've had patients who didn't necessarily need me to mention it to them. They're already trying to explore options for themselves.
But I do think it is critical for those of us who are doing this kind of thing to keep talking about it. I know sometimes I feel like, really, is there anybody out there following me on Twitter who doesn't know I have an artificial pancreas? But I hear all the time from people, at these events, or who follow me online, are like, wow, I had no idea that, this was the problem that you faced, or this was the reality of living with diabetes, or that this technology was out there. So I want to encourage us patients that even though it feels like we keep beating the drum, and surely everybody's heard, not everybody's heard, and there's more opportunities to reach clinicians like Perry and Michelle, who've become amazing advocates because they had the opportunity to engage with the community.
And I'm glad you brought up the community, because it's so important, and we are learning so much from the community. And Mila and Jimmy, I hope you don't mind that I tell this story. Last week I was having a research meeting with Mila and Jimmy. And on our research team is an internationally recognized expert in diabetes, both as a provider and researcher, or a practitioner and researcher, very well known and very well connected. And At the end of the meeting, this researcher said to Mila, "Hey, Mila, can I ask you a quick question?" She said, "I need to trial a piece of equipment for a vendor. Can you give me some advice on how to use that equipment?" She asked her woman to woman, mother to mother. It wasn't a scientist talking to a patient or vice versa. These were two people talking about how to use a piece of equipment. And frankly, I didn't say a word. I just listened to them talk. And Mila's answer was very elegant. It was very professional and very matter of fact. And she really taught this expert, this renowned diabetes expert, how to use this piece of equipment. That is the beauty of the community. That's the beauty of the citizenship that we're talking about here at this year's conference. And so you both have kind of touched on that a little bit. What more can we do to educate the healthcare community and healthcare providers, particularly about what you're doing? Maybe, Dana, do you have ideas on how we can educate other healthcare providers on?
Yeah, well, I think thank you to the healthcare providers in the room and online who are engaging this. I think having healthcare providers help create the opportunities for conversation is very key, because I am able to, be at the table in some conversations, but unfortunately, patients are not able to be at the table at every conversation. That's the reality. So having clinicians who are willing to say, look, I know that my network of other providers don't know anything about this. How can I create an opportunity for, you to come in and have a discussion? Or how can you create, a meetup or something where we can invite them and have them come in? I think that partnership is really key. But I think every patient out there is willing to share their experience and has been, but it's really about finding those right environments where it doesn't feel antagonistic of it feeling like it's clinicians versus the patient or FDA versus this and that. When it's antagonistic, that safe space for learning, that psychological safety that we keep talking about doesn't happen. And it's also very hard to share authentically and be very vulnerable as a patient if you feel like you're being attacked and criticized for something that you feel like is very matter of fact, and of course, why wouldn't I do that? So being able to be safe on both sides and create those opportunities, I think is very important for really spreading this movement.
And I completely agree, and I think that the patient with the story is so critical. Not all healthcare providers are online, and so we need to be able to go to those local conferences where providers might be. Just because, if you think about these national conferences, how many of providers actually go to those national conferences? They might go here or there, but even someone who's specialized in diabetes for as long as I still haven't tackled every single diabetes conference. I have to pick and choose. And so I think that it's really important to almost grassroots, go to those local conferences, train these groups of healthcare providers, and then move to the next community. And I think that takes, champions in that community, patients and maybe other healthcare providers who are familiar with that technology to really rise up to that.
And I would say conferences like this are very much pockets of patient-centeredness, but a lot of the traditional medical conferences held by the medical organizations, they don't have patients at the center. They don't have patients presenting about the technology that they're using. And so it's just a total missed opportunity. So I would say if you are a provider, you're a patient, go to that healthcare organization for your disease specialty area and ask them, why aren't you putting on sessions by patients for the clinicians? Because patients are such great educators. And if we don't start educating clinicians more traditionally about this technology, there's just going to constantly be a fork in the road where patients and the DIY tech is over here and the traditional model of education is never going to reach that. And that's a wasted learning opportunity for clinicians, and it's just a waste of all that data and patient knowledge that's been gained from the community.
Very good. Well, I think we should probably take a few questions from the audience at this time. Are there questions? In the back, I think you raised your hand first. Yeah.
As a designer and a maker, I really love this story that you're able to craft the healthcare that you need to perform your daily tasks. And I know, Dana, you had said that you had gone to the manufacturers and said, hey, this is how your product isn't serving me. Can you change this? And they gave you a variety of responses. And I'm wondering if you've gone back to them since then and said, look, this is what I did to solve my issues. Do you still have any interest in this? Because I'm not the only one doing it. And Michelle, also, have you been able to go to a manufacturer and say, look, this is an off-use product people are creating because there's a gap in their healthcare solutions that you're supposed to be providing?
That's a great question. So I have gone back to those manufacturers and talked with them. When just talking about the standalone CGM, I talked with the CGM manufacturer when they came out with their next iteration, and somebody was so proud and showing it off. I'm like, yeah, but louder alarms are still not a thing. Changing the alarm still not a thing. Like that's still just missing. So I've had the conversations just about CGM alarms, but I've also had many conversations with the manufacturers about the closed loop system, and many of them, because there's multiple. And it's just hard to tell if you're making traction because the design process of medical devices is so long. It's so many years. Like what's coming out now was baked 5 years ago. So when we're talking to them now and over the last couple of years, it's kind of hard to tell, like, well, when are we going to start to see traction and see that making a difference in terms of them actually changing their product? That's why I'm pretty passionate about talking about changing the speed at which these devices are made, because the feedback cycle is so long and it's really hard to see, is that going to make a difference or not? And by the time we find out, it's too late to help them course correct if they're doing it completely wrong.
And with regards to the question of whether or not I've gone back to the manufacturers, I have, specific to the Instagram study that I did where we were looking at CGM location. And the response that I got was how expensive it would be to redo a study using multiple sites. Because if you just, let's just say that you need to have 200 people in a site for just to look at the abdomen and the safety related to that and the accuracy, you would have to have 200 for every single location. And so the cost of that is quite great. And so I think that was a limitation.
One of the things I'm excited to hear is there's a lot of news coming out of the FDA, but they're looking at how do we use real world data as part of clinical studies. And I'm hoping that some of our communities will get to help donate data and basically do studies that can go towards getting different labeling for devices that are already approved. I don't know anything that's happening. That's just my 2 cents and my hope personally.
Hugo, I think you had a question?
My question is sort of similar to the question that was asked earlier, but it's more in terms of like how can patients and clinicians partner with manufacturers to help advance, create more patient-centric solutions to some of these problems?
That's an awesome question. I would say right now, this is like, for most manufacturers, what they're doing now is what not to do. And so they need to radically rethink how are they getting input and feedback and have patients at the center design process from the center all the way through. Post-market feedback is not enough. You really have to have patients helping design and helping work through all pieces. And right now, I think most companies are not designed that way. And so it's not an easy answer, but I think they definitely need to radically change the way that they're doing their business development.
From the clinician side, I think that it depends on what the technology is. If it's a tool or a technology that a patient's going to use, I think that it's more important for that patient to be at the center. If it's a tool like an electronic medical record on the provider end, then I think that a healthcare provider should be in the design process of that. So I think that we need to think about who is our end audience and who's the target audience for this, and then really design for that person.
Yeah, but hopefully designing with the person's data in their hands first, and not design for the company first and then the clinician and then the person, but person data first, then maybe also the clinician and then the healthcare company.
Are there any other questions from the audience? Yes.
Dana, I wanted to ask, a lot of people kind of want to follow in your footsteps in other communities, and I think that's one of the amazing things about the e-patient program. For somebody who doesn't feel that they are like technically the person to start doing this, what would you recommend as a way to get the knowledge in your own community and actually begin being productive?
I think that's a great question. I think that's why I really like emphasizing the community part of OpenAPS and We Are Not Waiting, because it is truly a collaborative community effort. We would not be where we are today in terms of the technology improving, in terms of the instructions improving, did we not have that community. So I think even if you're not a technical person, but you have an idea or you're like, we just need to change something, is focus on finding those people through social media and creating a gathering place. It can be as simple as a hashtag chat. It can be as simple as a Facebook group or a Slack or whatever it is where you feel comfortable starting to bring people together and having those conversations so you can have those productive sessions and find the right people. And that's one of the things that I'm hoping that my project will do, is help come up with kind of an ingredient list of here are some of the things that you are likely to need to help spark those conversations or spark those innovations to really be able to scale once you do have the right people in the right place. So I don't have a great answer for that question yet, but I think that's something that we need to think about and reflect upon is if we have a community that's working really well, how can we help teach other patient communities? And I would say keep asking these questions because different people will have different perspectives on why projects have succeeded and what makes it great. And I think that diversity of perspective is also a great piece of that community and why we've been successful, but can also help other communities who might not come out of the same place.
So thank you, Mila and Jimmy at home, and Michelle and Dana, of course, and you are a true medical pioneer, and so are you, Mila, and we thank you for what you're doing. Thank you very much.